go ahead and get started. And the ones that they missed out on anything, they can come back and watch the recording and stuff. So hope everybody's doing good tonight. Donnie, see you on there. I'm glad you're doing good. It's been a crazy week on the Gulf Coastal counties. I had an officer killed a couple days ago, and it seems like it never stops. Very busy area. I seen where there was also an officer killed. I think the night before last around Purvis. I think he was in a traffic accident. So it's definitely been a crazy week down there, to say the least. So it never stops. My hat's off to those guys, girls, all of first responders, really, because I've been a part of it for a long time, but especially those officers that was killed a couple of days ago that are in South Mississippi. We're going to pick up tonight on we finished off the other night on this oxygen delivery, and we're going to talk about some assisted and artificial ventilations tonight. I'm sorry, I'm just checking an email from Rob Roy. But a lot of times, I've had people that would state that they weren't really 100% positive about when they need to start getting involved, as far as when do I need to start assisting somebody in ventilations. And some people are very aggressive. They'll jump on an airway, seems like someone's having problems, and other ones that they may wait to see how bad somebody gets to do it, but a little bit of uncertainty when they need to get involved. So hopefully we can touch on some of those points tonight. And by all means, if y'all got anything to say, please speak up. I'm gonna try to take a break about every 35, 40 minutes. If anyone needs one before then, just let me know. I know I get long-winded sometimes. I get to talking, and before I know it, I've been rambling on for a couple hours. I won't notice until I started getting hoarse. So normal breathing, as long as someone's not injured or impaired, that could be a voluntary, or it can, your body breathes on its own without you having to really consciously think about it. So we got to remember what's normal. Remember, the most important thing you can remember is what is normal. What does it take for someone to maintain homeostasis and to allow the body to function right? So, you got to have a normal respiratory rate. You got to have an adequate volume in and out. And gas exchange needs to be available. So who needs this? So anyone, even if they are breathing, if it seems like they're gasping or if it's inadequate, if what they're doing is not right or not sustaining what they normally need, then it's time to get involved. Now you can O2 alone many times will not work, or it's not going to be adequate if the person is not ventilating the air in and ventilating it out without obstruction, without a whole lot of effort. And in order for gas exchange to really take place, the rate needs to be somewhat controlled, not too fast, not too slow, because the gas exchange is time sensitive, very time sensitive. Someone breathes way too fast, they're exchanging the air before the gas part takes place, before the gas exchange takes place. Someone that breathes way too slow, the carbon dioxide and O2 are going to diffuse. If it's breathing too slow, it's not getting the CO2 out enough, and it's going to build up even more. So people that let's say like irregular breathing patterns, if they're not maintaining an adequate rate, an adequate volume, someone that is altered, they're going to need assistance with this because of inadequate airway. Someone's altered, they might not be able to control that airway with their tongue, their mouth muscles, their structures, muscles that they would normally be using to create ventilation. So too fast, too slow. We got to think about what are there any reversible causes at this point? So before we even get to treatment, a lot of time, and it's easy to get caught up in someone saying, okay, well, what's going on? What's going on with them? when the person is lying there and they need support of the vital signs. So this is why the breathing ABCs is toward the top of the pyramid, because when you see a problem with this, it's time to jump on board and get it started. I've seen where, like in major trauma centers, and flight teams have brought people in and they've had a lot of equipment going, a lot of high-tech technology going on these patients. And they start giving a report, and the physician's just like, oh, whoa, everything stop right now. This patient needs resuscitated. And it don't necessarily mean they're in full cardiac arrest. However, it means that their respiratory rate, volume, blood pressure, the things that involve vital signs are in trouble. And until that's stabilized, a whole lot else is not really important at that part. So the altered mental status, the irregular breathing, excessive muscle use, when people start getting fatigued, it goes from respiratory distress to respiratory failure, and that's when we've got to start thinking about what treatment modalities we're going to use. But tonight we're going to talk about simple, going through the advanced that's appropriate for this skill level. And so some of the options that we have, and it's got a lot of subcategories. You got your assisted ventilation, you've got your CPAP, you've got, and you may need to enlist the help of some alternative airways. So let's talk about simple bag valve mask. And what do we see a lot of times go wrong in this? I know I see a lot of simply the bag not placed in the proper place. The mask, it may be, I've seen it turned upside down. You got to think that some people's facial structure, due to loss of dentures and things like that, it may cause getting an adequate seal. And if we don't get an adequate seal, that air is going to take the easiest way out instead of going into more resistant airway. Now, this is someone that we're doing assisted ventilations with. When we're trying, if they're not all the way apneic, but just maybe an irregular or ineffective breaths, we need to try to time our breathing or the bag valve mask device every time that the patient breathes. If you try to do it when they are not breathing, you'll get resistance. And a lot of times that resistance will cause them to get anxious, and then you'll get someone that's just non-compliant or not cooperative. So we need to, let's think about, watch them when they breathe, try to predict it, breathe when they breathe. And once you get them used to that, if they're conscious at all and able to talk or follow some suggestions, maybe coaching them and explaining to them what you're trying to do. Hopefully after you get some compliance with the patient, they'll start to adjust in what you need to do. Now, in a little while, we're going to talk about rate and tidal volume and minute volume. And I've got some slides and numbers that I want to show you about how that kind of works and plays into physiology. Now, remember, what's normal for a patient? What is the body normally need to do for this patient to maintain homeostasis of adequate respiratory status? And that way, know what normal is. And that way, when there's a problem with it, you may not know what's wrong, but you can always tell what's right. So with positive pressure ventilation, it means that the patient's not doing enough respiratory effort on their own to form that vacuum on the inside of the chest. And it may be because they're not able to, or because there's a structural problem with their maybe rib wall fractures, or something blocking that, like a pneumothorax, to where the air cannot get in. And that's when it's going to require some help. Now, when the body functions normally with adequate breathing, every time you take a breath, normal breathing allows blood to be drawn into the heart, to the chest cavity. For example, when someone takes a breath, it not only forms a vacuum with the air, but it can also pull the blood back into the heart and allow it to be pumped again. Now, this is with normal rate and volume. Excessives, like if you bag somebody too much, overinflation, or too fast, then that's going to cause the amount of blood returning to the heart to be reduced, and cardiac output's going to fall with that. So also, like you got to think about when the lungs get inflated enough, that air is going to spill over. And where's it going to go to? It's going to go down to the esophagus and the stomach, cause some abdominal distension, and that also is going to cause decreased chest capacity. It's going to decrease the air going into the lungs, and not only that, you got a risk of the patient vomiting, aspirating, and all that coming back up on you. Now we talk about the PPE, protecting yourself against germs and infectious diseases. You remember the barrier devices. There's a lot of simple ones out there. You got the shields, the face shields, the mask, mouth to mouth. That is, they used to, years ago, they thought nothing about doing that to a stranger. But as times are now, that's why they went to teaching only compression only CPR in a lot of cases. And unless it's a family member or something like that, it's not going to get done as far as mouth to mouth. So you got to remember, back up to mouth for a minute. If whatever that patient has, or whatever what caused them to go down, or whatever communicable diseases they have, they're going to be passed on to you, very likely, if they have that. Now, mouth to mask is the preferred option. We see that in a lot of our basic CPR classes. It's simply, a lot of times, it's people don't have availability to that. I know there's supposed to be on all the ambulances a rescue mask, but that's something we rarely don't even have to use in the ambulances anymore. We do have those in first aid kits, or maybe some lay people would have that into a kit or something like that, to where they can use it in order to get to perform ventilations on a patient to someone they may not know, or even if they do know. Oxygen concentration when someone is needing assistance, it needs to be at the highest level, around 15 liters a minute. And that's and the reason it's normally they don't get the normal O2 intake is not going to be that high, of course, not that high of a concentration. But when someone is not breathing right and they've got lung compromise, it may be because they have some fluid in the lungs, or they don't have the compliance that's required to adequately take an adequate tidal volume. You have to make up for it in the amount of oxygen that's getting into the lungs. So that's why we need to do high flow O2 when we're providing assistance as far as ventilations go. Now, the bag valve mask, pretty much the closest thing to 100% you're going to be able to get. We don't use both hands to squeeze it completely to empty it out. We only want to put enough in to make the chest rise, which is roughly around 500 cc's by the thumb finger squeeze for an adult. Now, you would have to adjust that, of course, if it's a smaller person, but that's why you're not really going to be able to measure the air going in with the bag valve mask, but we're going to have to just watch for the chest rise and fall, and that's going to have to be enough. If it takes too much, then we're not going to, then we could actually hurt that person. Remember, if it works better, it's almost impossible to use a ambu bag or a BVM by yourself and try to do CPR, but going back and forth, because it actually takes more time to put the bag back on there than it would be to just do like a mouth to mask if you're by yourself, unless you do have some type of other airway in place. Some of these bag valve devices have a peep valve on the end of it, and that simply causes some backflow. It's kind of like what a muffler does an engine. It causes the alveoli to stay open, but not all of them have that, but some do. And the ones that do have it, it's actually been described as far as it does make a difference as far as resuscitation and oxygenation. Now, there again, the oxygen is about 5 to 6 milliliters of air, which is about roughly 6 to 7 milliliters a kilogram for the patient per breath. And I'm going to show you some numbers later. It's not nothing you have to commit to memory or anything. It's a lot of FYI stuff about figuring these tidal volumes and respiratory rates. So, familiar with the EC type securing of the mask? You want to be able to, when you make a seal on this, and I know we're repeating a lot of stuff, but with the, we know how the people have a lot of beards. Sometimes people are obese. They don't, big floppy tongue in a way. If a bag valve or assisted ventilations need to be used, that person really needs to have an airway adjunct in place, whichever one that they are able to accept, in order to be able to get the air in appropriately. Because a lot of times the tongue will fall back against the back of the throat. They're not able to hold the secretions in place like they should, or not able to swallow. So that's why we need to have a good seal to get past all of that. We used to have these on ambulances a long time ago, demand valves or flow restricted devices, and they went away for a lot of years, but now many places they're starting to come back. And it's very important to know how to use these things. Back in the old days, they wasn't really flow restricted. You just kind of squeeze the triggering device, and when the chest rose, that was enough. But there again, there was a lot of injuries caused to that. That's why the ones nowadays, you have a set rate or a volume or a relief valve to kick off. You set the pressure, how much pressure might be going in, or actual volume delivered. And it's not a bad tool, especially if you're by yourself, if it's used properly. Like I said, it's easier for a single rescuer to use, and it reduces fatigue, because if you're bagging somebody for a long way through the countryside or a rural area getting into the urban area, bagging someone does take a lot of effort and wear you out pretty quick. Now, does anybody out there have any transport ventilators on their ambulances? They got like what they call an ATV, or automatic transport ventilator, on a lot of ambulances that don't really have the critical care aspect on some other like flight and stuff like that. But does anybody use ATVs on their ambulances presently? They the ATVs, ATV, I mean automatic transport ventilator. They're not made for long-term use, for the simple reason they're not real forgiving. They Some of the more advanced ones will have settings on there that will allow the patient to accommodate. All right, Donna, thanks for that. I know I used to work for Acadian a long time ago, and they did have some. They had some more advanced on the critical care truck, and a lot of them. And you're probably not going to have these a lot if you're like with a first responder, first response unit, because there again, it's mainly for more long-term care, or when I say long-term care, for extended transports or inter-facility transports, where someone may need the continued ventilatory support. Now, if someone's having to have constant support, ventilation support, the bagging them sometimes can cause issues, because not every breath is going to be the same when you're doing a BVM, and the rate is going to change when you're doing it. So the ventilator sometimes does have a more reliable deliverability with these than someone will just bagging the patient. So, and what I mean by these not made for long-term care, is for the transport ones, is the other ones, the critical care vents that we had on the helicopters and some of the ambulances, and ones they use in like in more long-term acute care facilities, they allow, like if the patient has some fluctuations in volume, not every breath that they take will be the same. That's why that may be relied. You can set it to like how much pressure is getting into the patient, or you can actually get a tidal volume. You want an exact volume, or there is one called PRVC when it can actually work with volume and pressure, how much goes in. Using these on kids, a lot of times they'll want to use more pressure regulated delivery instead of volume, to keep from overinflating a kid's lungs and hurting them. So, and You'll set rate with these simple ones, tidal volume, how much air goes in and out, and of course peak inspiratory time. Now on the right hand side of this screen here, you'll see at the top where it says like heart rate, SpO2, FiO2, PIP, VT, BP. I'm going to talk to you about what some of these are, and I've got another screen in a minute that gets a little bit more explanatory with it. Now, by all means, please speak up and say something if you need more clarification on some of this. Now, this chapter here isn't meant to teach you to be proficient in a vent, that you can walk away from here and start using one. But right now, we're explaining the whys and the hows. So, let's say we have a patient, and we're going to be transporting them from hospital A to hospital B, and this patient is vent dependent. They've been this way for several years, and we're going to have to switch them off over to our vent on the transport team. For the simple reason, if they have a personal vent, it's a good idea, if it's at all possible and your protocol allows you, to take them being transported on their personal vent. That will be so much easier on you and the patient, because those settings have been accommodated to that patient and the patient is used to it. Now, if we take somebody and switch them over to another vent, you're going to get some resistance at first, and they're not going to like it right away. That's why when we move somebody over, we watch them a little bit, make sure they tolerate the vent well, and then go from there. Some people, now I'm talking about in paramedic and critical care scope, sometimes we've got to sedate people in order for them to be able to tolerate a vent. But for this purpose, we're talking about hopefully someone that's able to tolerate one long enough for these in-facility transports. But it's about the only time we're going to be able to use these. So first thing we're going to do is we're going to find that we're going to just measure the heart rate and the SpO2. Now the SpO2 is simply the pulse ox that this is picking up on the patient, and they're picking that up. Of course, the pulse oximeter on the finger, extremity, ear, something like that, is being fed into this ventilator, so it's going to give you that reading. FiO2 below that is the percentage of oxygen this patient needs to receive. Now, 21%. That's pretty much breathing air, what we're sitting around breathing right now without any help. So sometimes these patients may be on 21% oxygen, which is, they're not really having an oxygen problem. They've got a structural problem, a problem with ventilation, not really a problem with gas exchange. Where we would make an adjustment with this would be, let's say that SpO2 starts to fall into the 90s or 80s, then we would need to adjust that FiO2 up percentage wise. And what happens a lot of time is, if someone is already if they're maintaining, if you get there and it's like, hey, they're 98% at 21%, you're probably not going to have to do a whole lot. But sometimes we will go up in increments of 10, 15, 20% at a time to monitor and maintain that pulse ox. Now, underneath that, you'll see something called PIP, which that's peak inspiratory pressure. And they usually want to top that off at around 30 millimeters of mercury. 30 to 35 is on the top end of that. So this person is doing about 27. That's what their pressure is in there. And that may be what their normal airway pressure is, what they're being resistant on. But when that's the amount of pressure that vent is pumping air against inside the lungs. Now, let's say, okay, we're at 27. I'm good with that. And you see below that, you see that little number that says PEEP, PEEP of 5. PEEP is positive in expiratory pressure. And that's what keeps the alveoli open. We talked about earlier that backflow, that PEEP, kind of like what CPAP and stuff does. We'll talk about a little later. But that keeps those alveoli open. So let's say they're doing it, and everybody you need some kind of PEEP on everybody except like severe COPDers, and they already have enough PEEP because it's just not coming out. So what PEEP is the air that's held back in the alveoli to keep those alveoli open. So, all right, we're running down. We got a PIP of 20, they've got a pressure 27, a PEEP of 5. Okay, that looks good. Now, if you look back at the PIP, on the right-hand side of that, you'll see 35 and you'll see 10. They've got their alarm pressure set at 35 which if it goes, if the alarm's going to go off at 35. If it gets too high and if it gets too low, it's going to go, it'll go off at 10. Now, what would cause those pressures to change? So you figure you got 27 airway pressure on the inside. If they start to cough or resist or something, you're going to see that pressure go up because they're actually coughing against the ventilator and the pressure is going to go up. So if they're coughing, temporary things like that will usually work itself out. Now, let's say we have a patient that's looks like they start to get distressed. You see this number go up to 35, 40. There's something wrong there. You either got, it is having to blow against something that it shouldn't have. The first thing you would check is your equipment, make sure it's working right. Is the tube kinked or the hose kinked? Or this could also be a sign of a pneumothorax developing or something in the lungs that's causing it to be obstructed. So that a lot of times in flight, you can't really hear the breath sounds anymore. So you keep a close eye on that PIP. You know, people with chest trauma or something like that, and all of a sudden that PIP starts shooting up and pulse ox starts dropping. You got to think, hey, this may be a pneumothorax developing on this patient. So, everybody follow me so far? Okay. On the below that, you got tidal volume. That is how much air that needs to go into the lungs to support enough lung volume for this patient to get. Tidal volume is the amount that rushes in. So if you're pushing 500 in, about 120 of that is in the dead space. Now, what some ventilators do automatically is account for the dead space so that 500 is delivered in excess of the dead space. So if that patient, for example, and this is just an example we're talking about. So if that patient has 500 tidal volume going in, and we're take off 120 for the dead space, that shows that they would only be getting 380 delivered to the alveoli. So that's why a lot of these ventilators already accommodate for that. And how much, I'm going to show you in a minute how to figure tidal volume so you can think back on this scenario here. Next, we set the, would set this person's rate, breaths per minute. And there again, I'll show you a formula a little bit on how we determine what rate to set it at. But for the most part, if the patient already has a spontaneous drive or what was they on already before you moved them over, whatever rate they were maintaining and tolerating, that's probably where you want to start with again. There again, we don't want to go too fast or too slow. We want to be about right. Now, what I don't see on this is, I don't see an ETCO2 measurement on this, but let's say, for example, make sure I'm getting ahead of myself with this. Let's say, for example, this patient has, remember our ETCO2 readings, we want to be about 35 to 45. Let's say, for example, we're at 12 times a minute on the breathing. And the ETCO2 is like 54. So what happened is we got CO2 building up that we need to blow off. So how could we blow that off with these vent settings? What would we need to do with the vent settings to blow this off, that excessive CO2?
Increase the respiration.
Yep. You would increase, ETCO2 is managed with respiratory rate and tidal volume. Now, which would we do? Let's say if their volume's already at 500, it's like, well, this patient might not can handle that much more. So we would increase like the rate. Let's say this person was already at a rate of 18 or 20 and it's not falling any, then that's when we might want to go up on the volume. But ETCO2 is managed with respiratory rate and tidal volume. Now, Spo2 Pulse Ox is controlled with FiO2 and oxygen. So that's a real simple explanation of how that vent works. And on the side, you see these white buttons, and you would like click on that and set your, like FiO2, you would click on the button to the right and be able to adjust that up or down with probably your little middle dial there with the arrow going one way or the other, and adjust that up and down. So that's how that vent would work. That's pretty similar to what I used to work with on the coast when I worked in the flight program. We used a more advanced vent, had a lot more settings on it, and it formed the job as well. But as far as this little vent here, looks like one. It does take care of what you'll need for short transfers. Now, there again, if someone is going on a long trip, this patient might require settings and something that, oh, it's not a good picture at all. Okay. They might require settings or something that we're not able to accommodate, and they'll have problems with that. What do you do if you have a patient on a ventilator and they start having trouble? If, we have to troubleshoot our vent, but what do we do while we're troubleshooting the vent?
You may have to manually ventilate it.
That's exactly right. Sometimes we have to, like, okay, there's a problem. Okay, take the patient off the vent. Let's work on the vent while we take care of the patient. So that's exactly right. Remember, when the advanced, this advanced stuff is great, but remember your basic safety nets. Hey, if this stuff isn't working, we're going to fall back to, we're falling back to what we learned from the beginning. We got to make the air go in and out, bottom line. So this is another type of ventilator that my picture's not showing up real good, so I apologize if it's not, but it kind of shows setting tidal volume, your peak pressure. They have the same functions. It's just why it needs to be familiarized with to be able to know how to work it. But as far as the pathophysiology of the vents, they all pretty much similar, pretty much the same as far as the modalities of it. It's just being familiar with the function of it. Now, we're going to talk about using these vents, just some FYI. So the vent needs to be supported. Some of them attached to, first off, I'm going to say securing the ventilator itself. It needs to be secure. And those portable ones are made to where a lot of times they can attach to a stretcher, underneath the stretcher, or close to the patient. I've actually laid them, secured them like between the patient's legs to where, as long as the other hose had an adaptable oxygen source. So a lot of these vents will not work. I've seen a lot of people want to tie them to just the Christmas tree that's on the regulator and turn it all the way up. You're going to have a lot of problems with that. On some ventilators, oxygen delivery devices, some regulators, they have underneath the bottom of it, they'll have it where you can screw an oxygen hose onto there and attach it to it. That's where vents and CPAP machines should be attached to, not the end of the device to where you open it all the way up, because you will have nothing but vent alarms when that happens. So getting it set up, you got it mounted, you're setting your rate, tidal, and volume. We're going to, and there's ATV, or automatic transport ventilator tubing. So which one would you use, 15 or 22? Now, 22 is what they use for adults. 15 millimeters is what they use for pediatrics. So we'll get that put on. That attaches to the ET tube or other advanced airway device. Some of these people may just have this ventilator attached to their trach. So that would apply as well. You need to check the patient out before you put them on your vent. You need to listen to their lungs before they go on your vent, make notations, make sure that, hey, they've got adequate tidal volume, and note how the patient is tolerating it, and before you move them over to yours. and note those findings. You want to have good chest rise and fall, and you want the sounds to be equal. And if you're not sure if they got some irregular lung sounds, be sure the sending facility is able to tell you, hey, this patient does have decreased breath sounds on this side. They got a bad pneumonia. Think back about your pressure for a minute. Now, it's like this patient has a high pressure. The pressure might be 30. Let's say the pressure is like 35, and they says, well, they got pneumonia real bad. So that would be something you might need to go down on your volume or setting of pressure or something of that nature, because you definitely don't want to injure the lungs with that. Now, like I said, the advanced ventilators go up to where you deal with people with ARES or acute respiratory distress syndrome. They'll swap back and forth from what we would call, let me show you this. On the bottom right here, it shows mode and it says AC. That's assist control. And what that means is that's going to give a breath every how many seconds you set it to give it at, regardless of what the patient is doing. There's another mode you can check called SIMV. And what that is, some patients have some respiratory effort, and that will give, every time the patient goes to take a breath, that will give them a breath. But if a patient don't take a breath, say like in 5 seconds, it'll go ahead and give one automatically. So it has a set rate, but it's triggered by the patient, whereas AC is not. And that's usually, like I said, patient selective and what they might need for that. So for the most part, the transport vents pretty much deal with rate and volume pretty much. Don't have a whole lot of other selections on there. The pressure relief valves, what it talks about here is if there's one that's in, if there's one of those in place and the pressure gets too high, it'll actually pop off, and so the lungs will not be inflated anymore than what they have to. But what happens sometimes if someone has increased airway resistance, like I told you about the pneumonia or the ARES, where their lungs are so inflamed and swollen that they can't handle a lot of volume, but the body needs this. And a lot of them is regulated with pressure. Well, we can't push 500 cc's of air in there, but let's give enough volume. Let's try to get that as long as the pressure doesn't exceed, say, like 27, 28, 30, whatever your settings may be. That's simply the way those pressure relief valves would work. Now, this is, you can get your pen and paper calculators out. This is just for some fun right here. How do we determine a tidal volume in a patient? First off, we got to figure out what a patient's ideal body weight is. It's not what they actually weigh, but it's what they should weigh. And there's a couple of formulas out there. And first off, you'd need to know their height, and we divide their height into inches. The example here is like, the formula is 2.3 times every inch greater than 60 inches. For example, if somebody's 5 foot 8 inches, they're 68 inches. So we're going to do anything over 60, 2.3 times 8 is around 16. I rounded down to make it simple. And for males, we're going to add 50 kilograms to that 16. For females, we'd add 45.5. And you see down at the bottom what their ideal body weight would be, 66 kilograms for the male, for someone that is 5'8", and around 62 for a female that's 5'8". All right. Then the tidal volume is determined by the ideal body weight, and we're going to say 6 to 8 either cc's or milliliters of air per kilogram. So let's say this person, I'd always try to start off in the middle. That way I could go up or down depending on what the patient needed. So let's say I start off at 66 kilograms times 7 milliliters per kilogram. that would give me a tidal volume of 462 cc's. Now, some vents go by fives, some will be that accurate right there. So I'd want to be around 460 cc's, and that would be my tidal volume for this patient. Now, like I said, some vents automatically have it figured in to account for the dead space for the air that doesn't meet gas exchanges, which is in the trachea and the bronchi. All right, let's say this patient is getting 462 milliliters of tidal volume, and their EtCO2 is higher than higher than what I'd like. So I would need to increase, if I wanted to increase tidal volume, I could easily go up to 528. Now, if that didn't do it, then I'd think about working with the rate more often. So, but that's simply the way we would figure that tidal volume is the ideal body weight times 6 to 8 cc's or milliliters of air per kilogram. And that would be what my tidal volume would be set at, with those numbers there on the right. I usually go around the middle rate so I can go up or I can go down. Any questions on this part so far? Like I said, you're not going to be tested on this stuff right here. It's just, this is, to me, I believe if you're going to have a piece of equipment on your truck, we need to know how this thing works or what the physiology of it is anyway. All right, Donna, thanks. Now, there's another number that we need. How do we determine the rate? Every one of you right now, physiologically, you require a minute volume that keeps you functional. So how do we figure that? We're going to use that same 66 kilogram male. Now, to account for the dead space, it's about 120 cc's of air. So we're going to account for that in this formula. What we're going to look at is that I'm going to say 66 times 120 for the dead space is going to give me my minute volume. So 66 kilograms times 120, it means that your minute volume for you to sit there and do nothing, your resting minute volume should be 7,920 cc's of air per minute, or around 8 liters per minute is what you actually require to function. So how do we figure? Okay, we got how much the tidal volume is, so we need to determine how many times a minute we need to set our rate at. What we're doing here is minute volume divided by tidal volume will give you your rate. So there again, I start about the middle, and I do my 7920 minute volume divided by the tidal volume, which means I want to set my rate at around 17 times a minute. And you see how you can adjust your rates or your tidal volume. Now let's say that we got to always meet that number on the left. So let's say if we needed to decrease, let's say we blow off too much CO2 because we're breathing so fast for them. Let's say the CO2 drops below 35. So we don't need to breathe so fast, but this patient still needs the volume. We would actually do another formula. We would figure out, well, we're going to lower the respiratory rate to 15. So that means I'd have to increase my tidal volume to 528. So that's and we didn't do, on the helicopter, we didn't do any of this by memory. We had charts, and we double checked each time on the way to the call, or you got your phone calculator, but on the way, if any of you have ever had flight intercept or anything like that, a lot of times they'll ask you for a weight, and sometimes they'll ask you for a height. And that's what we're doing, and we're figuring these formulas out before we get there. And a lot of times we'll go ahead and have the vents set up with those approximate measurements. But that's why they do that. A lot of times they'll say, well, we got about a 120 pound, there's about 120, 30 pound male, and he's 6 foot or 5'8". And that's the reason we do that. So we can go ahead and get these numbers down. It's something we ain't got to figure out later. So does that make any sense? Anybody picking up something they didn't know before? So like I said, it's pretty interesting. So this is a lot of, like I said, FYI stuff, and I just wanted to kind of show you how these settings are made or how they're determined. So despite all of this, you may get somewhere and they have their own. Thank you, Michael. They may have their own settings already put in this patient. Well, you're like, man, this doesn't go with what my formulas add up to. Well, if that patient is maintaining well at those settings, well, we need to adjust the vent to the patient, not the patient to the vent, because honestly, the patient determines how he's going to act. Now, in order to take over, there's some times where the patient, what they're doing isn't working. It's not going to help them at all. And that's when we get into sedation, paralytics, and things like that. It's like, look, your body needs to take itself out and trying to regulate this and let the therapy work for it. That's when we would sedate and paralyze someone in order to, we're like, look, what they're doing is not working. We need to take over and do this till they get better. That's how that part works. So, when we get to the boot camps and stuff like that, we'll try to have a couple of these devices there so you can play with. All right, let's take a quick 5-minute break, right quick, please, and then we'll come back and talk about CPAP. Let's give it about 5 minutes. Get your cup of coffee, glass of water, run to the restroom, something like that, and I'll see you in a few minutes. Okay, I'm back. Let's talk about something that we are going to see a lot more of that has become a lot more mainstream than a lot than most other treatments, and that's CPAP. And CPAP, for someone that's never had it before, it takes coaching. It may scare people to death. And a lot of times the people that need it the most are scared of it, or they feel like that it is smothering them, that it is not giving them the amount of oxygen that they need. And there again, it takes coaching and encouragement and it actually steps in getting this to work in a lot of patients. And because I've had a very rough time sometimes getting people to comply to the point that they even were just so non-compliant that they would actually go unconscious and require intubating and stuff. Whereas if they would allow this to work, it might have kept them from getting that deep into it. So CPAP, it basically increases pressure in the lungs. It opens the airways. It keeps the upper airways from collapsing on each other. And it simply pushes oxygen across the alveolar membrane. It doesn't allow things to happen. It makes things happen. So it's kind of a step up. Now, CPAP doesn't force air into the lungs, but it increases pressure. It's like a back pressure. It is PEEP, if you will. It keeps the oxygen in the places that it needs to be longer. Now, like a non-rebreather, things like that, they'll go in so far, but that's not being forced in. And a lot of times the patient, if the patient, when do you go to CPAP? If the patient is on high flow oxygen, then it's not doing any good because for some reason or another, their lung compliance is just not getting it down to where it needs to be. So, hey, I got this guy on non-rebreather and he's not improving. He's struggling. He's still struggling. What does that tell you? He needs help. So let's get this air on down into the lungs. Increase the pressure inside his alveoli. So that's pretty much what needs to be done with it. So we try to get this on early if at all possible. Now, this has improved the quality of life in a lot of people as far as people that's snoring at night. They have sleep apnea at night. A lot of people sleep with CPAP machines. I do. And what happens with, let's talk about sleep apnea, for example, and that's a big complaint with a lot of people. And there's a couple different kinds. There's obstructive sleep apnea and there's central sleep apnea, to which one of them is because of respiratory center in the brain, and the other one is obstructive, and that's simply because, hey, the structures in the mouth fall back against the back of the throat, and they snore very, very loud. And I know myself, I used to, before I got the sleep test and stuff, I would wake up with a sore throat, dry mouth, and then I started getting these bad headaches, always to the front of my face. And it was to the point to where a lot of time I would take 800 milligrams of ibuprofen before going to bed so I wouldn't wake up with a headache. No, that's crazy, but that's what I was doing. And I was always fatigued. I couldn't stay awake during the day. I always had this sore throat. The uvula in the back of my throat was always inflamed. So talked to my personal doctor, and he's like, man, let's do a sleep study. It's the first thing he wanted to do. First thing they had me do is wear a pulse ox at night. And it dropped down very low several times during the night. Then the next thing, you got to go in and do this sleep study. And that's weird. It's hard to, I didn't think I'd be able to sleep with people watching me and all this stuff. But anyway, and they said that I had several episodes during the night where I actually quit breathing for sometimes a minute. And that would cause your, hypoxia, headache. That's what was happening to me. So that was kind of, I got put on CPAP, and that back pressure in the upper airways, I'll show you a picture of it in a minute. It keeps the tongue and everything away from the back of the throat. And I started getting some of the best sleep in my life. I actually started to dream, and which I hadn't been doing. So it is a very simple but effective tool. Even people use it in everyday life a lot of times. Now that's like therapy type CPAP. However, it comes to a point to sometimes when we got to use what I call rescue CPAP. And this is when someone is in emergent or acute distress. We're trying to prevent the need for endotracheal intubation because if many times chronic respiratory patients, if they get on a vent, they have a hard time coming off. And the reason that is the body just says, look, I ain't got to work to do this. Just let the ventilator do it. And so that's why it's real hard for them to get off sometimes. The lungs just simply don't want to work no more. They become, for lack of better words, the lungs become kind of lazy. And they simply don't want to do the work, just let the vent do it. That's why it's hard for them to come off. So we try to keep them off the vent if at all possible. So the CPAP, the backflow of air, it's simply to keep the alveoli open. It splints them, so to speak. And it's usually because these patients are in severe stress and their compensating mechanism is not working. Now, come on, picture. Now here's a picture of a basic type CPAP. Now, if you can see normally to where it keeps the tongue away from the back of the throat and those structures from collapsing. It takes a little bit of getting used to, but where this pressure comes from is not from the air going, really pushing it in, but when you breathe out, you're breathing against pressure, and that backflow causes the tongue to stay away from the back of the throat, keeps the alveoli open and splinted to where they can be ventilated right. So that's simply the way that part works. And there again, it can take getting used to, and some people have a tough time doing it, but I can actually try to snore with this thing on, and I can't. Wife has pulled a few mean tricks with me before to wake me up and kink my hose and watch me jump up from there, but that's another issue for another day. So our goal in this CPAP is to improve pulmonary compliance. Remember, compliance is the adaptability of the lungs to work and respond, and it's to make spontaneous ventilation easier, because CPAP requires a conscious patient. It requires them to participate in this. So how's all this work? Air pressure is maintained at a set level, whether you're breathing in or breathing out with a CPAP. Now, where that differs from BiPAP is that the BiPAP is actually two levels of pressure. One pressure when you breathe in and another pressure when you breathe out. That's BiPAP, and we're not going to cover that right now. But CPAP is a continuous positive pressure, and it maintains the small airways and keeping them open. It makes a tent. If you think of a dome tent or a tent, the poles that keep the tent up and open, that's what CPAP does for those alveoli at the terminal ends of the airways. So by opening those bronchial tubes up, it increases the oxygen capacity that can get to it. It increases the surface area, and it can also cause, like when you still have to give bronchial dilators and breathing treatments, it actually increases their efficacy like over 80% sometimes. So let's say if you've got fluid in the lungs, this forces the fluid out of the alveoli and back into the system. That's how it works with like CHF and pulmonary edema. And hopefully this will work. It will decrease the work that the patient has to do, because breathing, especially when they're fatigued, takes so much energy and oxygen demand for the work of breathing that the alveoli and the blood doesn't get what it needs to get. Now, inside the alveoli itself, let's say we have that setting on 10 millimeters of or centimeters of water, and the pressure of the fluid on the outside of that is about 8 centimeters. You kind of see how this works. This back pressure increases the pressure in that airway, keeps that open, and it also, since you got that higher pressure in the alveoli than what's outside of it, it keeps the fluid from getting into those airways. It reduces, like for CHF. If we can get people to comply with this, it reduces the fluid that's in there, and they will start clearing up. I've seen people turn around by this so much. Someone that has been used to CPAP and had it actually save their life before, they'll take the mask out of your hands and put it on. So that's once they had it, they see how this works, they are a lot better adapt to complying with it. This is at the distal end of these alveoli. That's like if you cut them in half, that air in there opens them up, puffs them out, and it causes all those capillaries on the outside of that to have exposure to the gas exchange. Now, just picture those sacs, the alveoli being compressed, almost collapsed, and you wouldn't have that gas exchange going on. You wouldn't have it. You wouldn't have it at all. So that's how that simply works to get down into that part. The next one shows, for example, how, let's say this is pulmonary edema, CHF, and on the left, there's no pressure in the alveoli. And what we see, if you'll see on the left, it looks like those two little, I don't know what you call that, two little rectangular / circle looking things on the bottom. Looks like maybe two Cheetos or something like that. If you see that space between them and that simulated alveoli, that is fluid. That's simulating fluid in there. And those are simulating the capillaries, and that fluid in between the alveoli and the capillaries, it shows how that fluid is not letting it happen. However, on the right, we put the CPAP on, they get that back pressure, and it increases that pressure, and you see what it does with the fluid in between the capillaries and the alveoli itself. So you see it pushes that fluid away from those capillary beds to allow the gas exchange to take place. So that's how CPAP works. It's not only used for adults, but it can be used for babies and elderly people, pediatrics, asthma. You know, what is it used for? Anytime someone's normal respiratory status isn't working. Now, the guidelines on this, and there again, you might, you fall back in your training. There's a lot of common sense that's going into play, but remember, be able to say why you're doing what you're doing. But for the most part, CPAP candidates, they have to be alert and able to follow commands. This is not you breathing for them. It's assisting. In order to assist somebody, they have to be in control or initiating it. In distress, moderate to severe, how long do you wait to see how bad somebody gets? You really don't need to do that. If CPAP can be applied early and they can tolerate it, then it's good to try to head something off than it is to try to catch it. Now, how do you know you might want to go to CPAP right away with somebody? You know, a lot of times they'll tell you, hey, last time I had to have the CPAP, or I sleep with the CPAP at home, I have to either they got swollen extremities, they got peripheral edema, and they're telling you, man, I have to sit up on the edge of the bed at home with my feet hanging down. I'm on oxygen at home, it's not working. I feel like fluid's building up. So you know right then, hey, we're going to skip all this other stuff and let's just go right to it. Because, of course, follow your local protocol. Because this is somebody you can turn around. If they get to the point to where they are in severe respiratory distress, start getting fatigue and failure, you're going to have to take the CPAP off because it's not working. If they're not able to spontaneously breathe, CPAP will not work. So that's why we want to try to get it early and don't wait till they get to extremes. Now, for the most part, CHFers, asthma, even COPD patients can benefit from this. But a lot of times, even after drowning, they'll put somebody on CPAP for a while near drowning, so where they still got fluid in their lungs, it can dissipate and get that fluid out of the alveoli, back into the system, pushes it out. Someone that is tachypnic, rapid breathing. Now remember, rapid breathing too fast, it doesn't give the gas time to exchange. So they're in a rapid breathing. They can still have a fast respiratory rate on CPAP, but this makes the air stay back into the alveoli, and hopefully with that oxygen increasing, that oxygen concentration increasing inside the alveoli, the respiratory rate may start to come down because it's like, hey, we're getting it. We don't need to breathe so fast. Pulse ox less than 90%. That's a great tool, but don't let that be your only determining factor as far as getting whether or not I'm going to use this. There again, it's probably not a good idea to let it get too low. They get panicky, they get non-compliant. So just start thinking about that in your head, to when I might want to go ahead and use this. Now your protocol, local guidelines, protocols may address these things, but but if you're able to say, okay, hey, why am I doing this? Well, the last time I was here, the last time this guy said the ambulance came, he had to be put on CPAP, and then that he's been intubated before. So that's somebody like, hey, you know what? I'm going to go straight to CPAP. If he can tolerate it, we're going to put it on and let's see if we can turn this guy around. I've got to the hospital a lot of times, picked up somebody very, very sick, and when I got there, they had improved to the point that they actually doubted that the patient was actually ever that sick before. I was doing an interfacility transfer one time. I had taken a nurse with me, and on the way back, we got a 911 call. We taken the nurse back to the hospital. We got a 911 call. Man, it was I dealt with this guy before. Big time CHF patient. He would get. He actually told me one time, "Hey, I need the tube." So I knew how this guy was going to go. And as soon as we got in there, he was big time CHF. I got the CPAP on him. Got nitro going. His pressure was like 250 over 150. Got his pressure lowered. Gave him some morphine. Gave him some Lasix. When I got to the hospital, the guy was breathing almost perfect and had turned around. And the nurse just kind of sat there and looked at me. He says, "Man, I'll never doubt you again." So there again, this is a great, great therapy, and it saves lives. So there, don't be afraid to use it. Now, of course, with everything, there's contraindications about this. If they can't speak to you or sit up, if they're not able to protect their own airway, it's not going to work, because they have to be able to participate. A respiratory arrest, this is not a something to where you control respirations with it. Now, why hypoventilation or hypotension? Why would we not? Okay, hypoventilation, which understood that it's not going to increase the respiratory rate, but why would hypotension be a contraindication for CPAP?
You don't have enough perfusion.
Well, that's one reason, but the reason I'm looking for here is, remember we talked about what happens if the chest is overdistended or overinflated. It decreases the blood flow that's able to get back into the chest to go out. It decreases cardiac output. So someone that is hypotensive, CPAP, with that back pressure being into the lungs like that, can cause the chest to be inflated, which would reduce blood flow back to the heart, and it would also compromise the heart in pumping the blood out. So that's the biggest reason for hypotension. And of course, with hypotension, if you're not perfusing, that, like she said, that blood will not be delivered, or that oxygen will not be delivered. So that's kind of like, hey, hypotension, it's a no-go with that. So what are we going to do? Well, they're going to probably deteriorate to the point to where we have to start breathing for them. But that's why that's why I say let's be aggressive with CPAP and get on it early and try to get them from getting to this point. Because when this happens, you're going to be pulling the CPAP off and taking over ventilations. Pneumothorax, chest trauma, closed head, facial trauma. Why couldn't you see why that would be a contraindication to that? How would CPAP affect like a pneumothorax?
would probably increase the pressure on that's already high.
Exactly. And if you already got a hole in that lung and you force more pressure back into that lung with that CPAP, what's happening there? It can actually make a pneumothorax worse. Or like I said, the chest trauma, that can always have a negative effect to it. Closed head injury, what happens there is it can actually affect intracranial pressure by making it can actually increase ICP with CPAP. And of course, facial trauma. If the face is not intact or structurally the structural integrity is gone, then we're not going to be able to get a good seal. Cardiogenic shock goes along with hypotension. The heart cannot handle any more stress if someone's in cardiogenic shock. It's not going to be able to pump against the force of that CPAP, and that thereby is going to make things a whole lot worse. Tracheostomy. We're not going to be able to use this in a tracheostomy. Active bleeding, nausea, or vomiting. Well, if they're actively GI bleeding, we can't have all that blood coming up into that mask and then going back down into the lungs. That's going to increase the risk for aspiration. Same way with gastrointestinal surgery. That, chances are there's some of that air that's going to get into the GI tract. And if they've had gastrointestinal surgery, we definitely don't want that air to go into the GI system and perforate a bowel or stomach, esophagus, or anything like that. And getting a good fit. If it's not fitting right, you shouldn't hear air leaks when you got it on. If it's not fitting right, it's not going to work because that pressure, that air is going to go for the place of least resistance. It's like, hey, this guy's got a beard. I'm going to squeak out through here instead of going into the lungs. That's what's going to happen, and it's not going to get to where it needs to go. Sometimes people with a receding chin or different facial structure, or sometimes if they wear dentures and they don't have them, it's going to be very hard to get a seal on these patients to get that air into the places that it needs to be. The excessive facial hair, we're starting to see a whole lot of that. I say start to see. It does seem, I don't know what it is lately. I know in my area, from personal experience, everybody I go to pick up is trying to look like people from the Duck Dynasty. And, CPAP's just not going to work with them. Some places do have nasal CPAP. We don't where I'm at, but that may be an option in some areas, and maybe a good suggested type of supplies or something like that to pick up. Now, who's used CPAP or assisted with it, and tell me about some problems that y'all have as far as putting it on somebody, or ways that you may have discovered that that make it easy for you. Go ahead, Don.
So I had a call about 2 weeks ago. I was sleeping at Station 7 here at Harrison County, and dude was beeping his horn. His wife was beating on the door. He was struggling breathing. So I get out there, not quite in a rest yet, but definitely struggling, definitely in a distress. And AMR got there, and they quickly put it on. He took it. There was no issues. I mean, he wanted it bad.
Yeah.
Unfortunately, it didn't really help him. His O2 stats were still down. He was still struggling. We did everything we could, but whatever was going on, we don't know.
Yeah, and he probably was into that spiral of impending respiratory failure. Once that starts, once the failure gets there, that's why it's good to head off. But once it starts, it's hard to really catch. Now, I'll be the first to tell you, I've been a paramedic for a long, long time, and respiratory calls are one of my I dread, because sometimes they get to a point, just like he said, and we can't get them turned around. Cannot get them turned around. And once they start that downward spiral, it really makes the anxiety level go up, not only on the patient, the family, but the medic as well, or the EMT as well. So that's why, when something like that happens, man, it's probably his heart had probably done got to the point to where these factors aren't working, and he probably ended up getting tubed and ventilated, probably, if not in the ambulance, at the hospital.
Well, what was weird, because they don't live too far from Station 7, but they drove extra like 9 minutes up here. But they could have drove 12 minutes south and they would have been to a hospital.
Man, they got a lot of faith in you, man. What can I say? But a lot of people,
hoping that I was awake.
A lot of people do that. They do. Maybe they don't know what to do. They just panic, and then, you know, I've had a couple of family members in life-threatening situations, and I wasn't thinking straight. I just wanted to get something done quick. So that may have been why that is. But these respiratory calls, man, that's why that I've emphasized, and I'll emphasize it forever, is that jump on them hard, fast, and aggressive, and try not to let them get bad. Because once they do, it's a different scenario. But I've actually had patients that I would let them sometimes hold the mask. I'd let them hold it at first, because if you start jumping right away, and you see how that thing looks, man, those straps and everything on the head, like this guy right here. Let it pop up on you there. This guy right here, if somebody gets in a truck and they're already or on scene, or your rescue unit, if you get there and they're already in respiratory distress and you go to slamming this stuff on them, I'm probably going to jump back too. It's like, oh, last thing I want is anything around my head. Now, if they've had it before, they're probably going to allow you to help them. But if they haven't, it's going to take some coaching. And what I've let them do is give them the mask and tell them to hold it to their face, and then I start putting the straps on. That's helped out a lot. Now, you can see this unit here that they got on the end of it. You can control the PEEP, that little green area. You can actually control the PEEP that goes in. And a lot of time that's set on around 10, or you can control the PEEP about 10, 15. I have actually seen people have to go up to 25 for severe patients. The bottom part of that is a nebulizer. You can hook a nebulizer to it so they can get that in as well. Now, it looks like this patient has a nasal cannula on, but what that is that nasal cannula type Etco2 monitoring device. So that it kind of measures your effectiveness of how good you're doing, how much gas exchange is taking place, because you want to be able to see that gas coming off. That's the way you can measure pulse ox going in, but we need to measure how much is actually coming out. But going forward, if you have someone that may seem anxious, let them hold the mask in place, let them feel it, let them get it to work, and then just kind of coach them. Says, okay, now since I'm going to go ahead and put this to hold it in place, because you're doing really good with this, I'm going to let this hold it in place. This way, you don't have to sit here and hold it the whole time. And let them sit there and let them breathe with it for a minute. Let them accommodate to this, because I'm going to tell you what happens, and I've learned from experience, is that if a lot of people don't really panic on a call, but they don't realize that they're able to do something. And what they'll do is they'll get in a truck and they'll haul butt, take off real fast. And it's like the patient, not only they're scared to death, well, they had to call you. And here you are trying to put all this stuff on them. And then you're probably, you're going down the road, priority one, and they're like, what the heck's going on? You're not going to get compliance with that. But you got to start thinking, what does this patient need? And you're like, hey, I can do that. So let's do it. Be an advanced EMT. Put this stuff in place and allow it to work. And if it's working, if that patient is working and satting good and they are improving, there's not a lot of use to run priority one and risk that to them getting excited and stuff. Now, there again, if you have to, just be able to say why. Hey, I was almost out of oxygen or something like that. Just be able to say why. You will go through, if at all possible, leave them on a big tank as much as possible, but that will empty a small tank in no time. No time. So there again, be aware of that. This type CPAP, is really not good for long transport times, because one thing, you're going to run out of oxygen, and it's not the most comfortable thing in the world. Now, they are transport type CPAPs and things like that, which is not all places have them, and the ATVs, the automatic transport ventilators, aren't set up for CPAP. However, a lot of the more advanced ventilators are. So, that there in itself may be a challenge. But if the patient, that's one reason why you want to do this with patients that's able to participate. It may help that you let them actually help apply this mask in place. And it's not just for the old. A lot of babies, premature babies, and a lot of times babies that are having respiratory issues inside the NICU or the nursery, they don't have the necessary surfactant, which does the splinting and the tinning of the alveoli to keep them open. They may not have that when they're little or when they're premature. So that's what the CPAP is in place for, to keep those alveoli open, and so the body can function, it can perfuse, it can get the proper gas exchange, and allow the lungs to develop. Now, this baby has looks like it's got a lot else going on. It's got a feeding tube, a suction tube, got it on nasal BiPAP, and he doesn't look real comfortable. He doesn't look real comfortable at all. And this is hard on the baby, the mom, and all that stuff, the parents, and take specialized treatment. We're not going to put a baby on BiPAP or CPAP in the field. Now, we did it at the critical care level, but we just don't have the equipment. That vent you carry, a lot of the automatic transport ventilators, is not suited for this. So if the small baby needs ventilatory support, respiratory support, then you're going to do that manually and very carefully. We're not going to put a baby this size on a vent. It takes a special vent. That's why we have NICU and ICU transport teams, or critical care pediatric transport teams. That's what it takes. In most EMS agencies, first response agencies, we don't have the equipment or the technology to take care of someone this little. But it works. It's one of the best medical features ever invented. Now, can't talk about the good stuff without talking about some of the complications. And some complications can be managed, and some of these we've already hit on. But the biggest challenge I found is non-compliance with a patient. A lot of them, they'll resist it to the point that they get real sick, getting a failure, and then I've actually had them resist it so much that I got to the point that they deteriorated to the point that they required me to intubate them and carry on like that. Remember the possible barotrauma, which means trauma from pressure, can cause like a pneumothorax. It can also cause increased pressure in the chest, and it can cause hypotension with that. So those are some possible complications. And if you see a complication develop, you stop whatever's causing it. Some other things that may happen along with this is, of course, gastric distension. We talked about, that's why that air bypass in the lung field getting into the GI system. That's why we wouldn't want to do this with somebody that has recent surgery of the stomach, or perhaps gastrointestinal disease of the esophagus, like an esophageal varices or something like that. Those are some considerations, because let's say they get a lot of pressure in that esophagus and they rupture a varices. So good history taken is imperative when things like this. Now, that would be maybe something you would have to call your med control on them if you are unsure. So whatever your local guidelines tell you to do, if you're unsure with the situation, and I've done this as an experienced paramedic, I've called and said, "Hey doc, here's what I got. I know here's what I can do, but I want to run this by you and get your input." They may tell you, "Hey, well, go ahead and do it, because we don't want him dying from respiratory distress." So, I've been told something like that. Well, what's worse? Is he going to die from this, or is he going to die from that? So, but at least don't be afraid to run this by somebody, a physician or med control director, if you've got some possible concerns that may impact this. So but the gastric distension, let's say that someone already has a swollen abdomen, and it might be due to like ascites or cirrhosis, some kind of inflammation that's caused the diaphragm to be pushed up into the chest. And putting any more pressure in there is going to cause the pressure to become excessive, and you may have the problems with the cardiac output and them getting hypotension. So there again, that is a consideration to be on alert for. And when these complications arise, your concerns, be sure that you, even if nothing happens right away, but you might want to follow up with this with a medical director or educate or quality assurance person or something like that who you work with, and like, hey, here's a problem I had before, and I think these things should be discussed and learned from. So it's use these as a learning tool when you have an issue like that. First off, don't do nothing wrong. If you know, hey, this is probably going to hurt this person, then don't do it, and then talk about it later. The people that have like a laryngectomy, some people may have their larynx removed. Tracheostomy, stoma, tracheostomy tubes, all of those that are there, they a lot of times won't work with CPAP, of course. Now let's talk about, without the use of CPAP, some of these issues that somebody might have with this. Now, we do see a lot of people with tracheostomy tubes to where they've got the stoma in the neck. The larynx could be removed, or they could have problems with dysphagia. They can't swallow. They're not able to speak, whether it's from a trauma, a stroke, or something like that. These are some patients that you have to treat as well. So some people can move air in and out of their nose and mouth with the stoma. Some of them are able to plug it off and speak. But if that's their primary way of breathing, then you may have to put a mask or ventilate through the stoma. Now they're made to where they do fit, and a BVM. They trach mask. Not all places have trach masks, but for the simple reason you can actually put a non-rebreather or something like that over that, and it's going to work just as well. Many times these things can become obstructed or get full of fluid, phlegm. It is a source of infection for a lot of people that get pneumonia through that. But a lot of times when someone needs suctioning, you have to suction through that stoma. Many times when you do, it's one of those, not the rigid catheter, of course, that we used to look at, but it's going to be the very soft ones, the very flexible ones. So they are going to be what you would use for that. Sometimes now this stuff gets so thick, very thick, it's almost like concrete without the water, very, very viscous, and it's even hard to suction with that. And they require some type of saline irrigation to loosen it up before you can suction it. Now, who is the best one to inform you of that? And a lot of these patients are at home, they're able to care for it themselves, or they have family members that are familiar with it. So if it's outside your scope, you're not familiar doing it, you can ask them, said, hey, do they, and they'll probably already tell you, we have to put the saline drops in there before we can suction. A lot of them will already tell you that, but that's what they're doing. It's because it's so thick and viscous. And when it gets thick and viscous like that, it's because it lacks water, it lacks fluid. So these patients are probably already dehydrated and probably subjected to being septic. So that's ways that we deal with these stomas. Now, these things can also come out. They can come out sometime. And a lot of times we get them where they're dislodged. And you can do ventilations over that. bag valve to the stoma if possible. There is a mouth to stoma procedure that some people may want to do, but if that, I've seen where the trach tube has came out before, and I was able to ventilate over that device. Now, or if it's just a hole in the neck, but sometimes a big adult size BVM mask would be too big for that. And I'd still use an adult BVM, but I might have to get a smaller mask in order to make the seal over the stoma site if the tube was pulled out. But the tracheostomy tubes, they usually have like a little T or butterfly on the end. And they go into the trachea and they aim downward toward the carina. They should have something to secure them in place, and that and be sure you monitor the security of them when you're moving them around. Don't let the weight, if you have to bag somebody through the stoma, through the trach tube, don't let that tube support the weight of the bag. I've seen people where they move somebody and they'll just let the bag hang with that. And a lot of times you'll pull that out, and then you've got another issue to worry with and some explaining to do. But don't let that weight of the bag hold on to that. And in fact, I know a lot of times I've actually had to hold on to the trach tube while I bag the patient just for that extra security to make sure it didn't get pulled out. If you have, if you're on scene with fire department or another responding agency, enlist the help of moving these patients while one person secures that airway. Like if someone's intubated or King airway in place, or they're being ventilated, who's ever controlling that airway, that should be their only job, supporting those adjunct devices so they don't become dislodged, because then you'll have another issue to worry about. I've seen where these tubes sometimes would come dislodged out of the trachea and get placed in subcutaneous tissue, like between the trachea and the neck muscle or adipose tissue around the neck. And some people would bag them and it would actually cause subcutaneous emphysema because it wasn't getting where it needed to go. So those are some things to think about. If you start to see some swelling or edema or distortion in those areas, it's what it could be from. Again, these tubes are about 15 millimeters adapter for peds, 22 for adults, and the attaching your BVM directly to that device is a way we want to secure that. Now, don't push it on, connect it, but I have seen, and it always seems to happen at the craziest times, is when if you twist these devices a lot of time, it'll actually form a bond and make it very difficult in order to separate those two pieces again. So just be aware of that and think about that. You just want to push it on, but you don't want to do the twisting motion like if you were trying to set a piece of PVC pipe or something. When these tubes, and they will become dislodged, a lot of times you'll get to the house or the pickup site and they'll say, hey, the tube came out. And so be sure to take that with you. And a lot of times they will actually have a backup. I know a lot of nursing homes do. They'll have a backup present, or even places that are on continued care at home will have a backup present and they'll give to you. So be sure, ask them, say, hey, do they have a backup or they have a new tube here with them to replace this one with? Because those are usually adapted, or their surgical area is usually individualized for that person to be around that specific type device. So if they have it with them, take it with you. These patients, a lot of times, it's not a big area to breathe through as what they would normally be through their mouth and their nose with. So they don't tolerate periods of hypoxia very long at all. Even brief periods of it will get them upset. Now remember, some of these patients may not have respiratory drive, and some may, but some may not have respiratory drive, and they're hooked to a ventilator with this, or something that controls their breathing. So even if you take them loose from that any at all, they're going to feel it immediately, and they're going to become anxious and upset. And what's real bad is, you got to think about this, is they might not be able to express that to you. So that you want to make these motions deliberate and exact. It's like, okay, I'm fixing to swap this bag over, this tube, I'm going to take this ventilator off and switch them over to my bag. You want to secure that tracheostomy tube. You want to hold it in place where it don't slip, disconnect the vent, and automatically hook your BVM up to that, because you don't want that interlude of space there. Now, when you start bagging a patient, they may not like it at first. They may not be used to this at first because they're used to their vent. They were comfortable on whatever settings was doing that drive in the first place. So talk to them, and if they're able to communicate at all, say, hey, do I need to slow down? Do I need to speed up? Are you getting enough? You know, it's very important not to lose communications with these patients, because just imagine having your ability to breathe in somebody else's hands. So that's what's happening with them. And, you know, I know when it's my family that's being treated by medical crews or whoever, I'm watching every move that they make. So, you don't do it for the fact of just because people are watching you, whatever, but just put your hands, you're in the place of that family or that patient. You know, how would you want yours treated? So not being able to breathe is probably one of the worst feelings you can have. So be alert of that. Dental appliances, dentures, partials. Sometimes these implants or caps can break off and go down someone's throat. They can become lodged in the airway, or these like loose dentures or partials in the mouth. The mouth's going to lose its structural form. A lot of times it will collapse, and they're not going to be able to be ventilated properly. But if you are bagging somebody, or if the dentures or loose things are in the way, if they fall loose when you're doing that, take them out, because we don't want to risk a bigger problem and a more dangerous airway obstruction. So we don't want to do that. All right, facial bleeding from the nose, the mouth. A lot of times if they're lying supine, where is this going to go? It's going to go down their throat. They're going to fight you. They're going to aspirate. So if it's external bleeding, we control that with direct pressure. But internal bleeding, we need to have suction readily and available. Any time you're having someone that cannot control their own airway, or you're trying to maintain this, let's say they have to lay flat due to spinal immobilization, but they have a risk of bleeding or vomiting. I will unwrap my suction device and have it stuck right by the patient's head, because when you need it, it's not the time to unwrap it, hook it up, and assemble this. That's not the time to do it. So anytime I have that possibility, I'm going to have that stuff ready. And not only, they may not even have a lot of bleeding or anything like that, but if someone's laying flat and in the back of that truck, they're looking straight up, they may be at risk also of motion sickness, getting nauseated or vomiting because of the motion sickness. So there again, you need to have this suction device ready. And if they're cervically immobilized, they're not going to be able to probably swallow or manipulate movements to accommodate deeper breaths or vomiting, of course, if they wasn't. So have that device ready and ready to suction out. So sometimes they vomit so much or bleed so much that the suction is not enough, and you'll have to turn them on their side or position them to where the blood will just run out. Even if you have to transport someone on their side, hey, I'm able to say why I've done this. So transporting on their side to keep the blood and the drainage from getting down their airway. I had I intercepted a patient one time when I was on the helicopter who had facial trauma. They had shot in the face. And when I got in the back of the ambulance, because I had my nurse with me, and she was an excellent nurse, but new to pre-hospital. And we had this patient laying on the side, and the paramedic and he had a suction tube in one side, and it was running out as fast as it could suction it up. And the patient was on the side, of course, and we were going to have to take this airway. So we had the paramedic, man, he had everything done except for this part. The guy was by himself, and he had his partner, but man, he was, I've been there, so I felt for the guy. So we got up there and I got to the head, and the nurse starts, I tell her, I said, we're going to put this patient underneath and we're going to take this airway. So they we sedated and paralyzed, and I intubated. The nurse was like, do you want to roll them on their back? I said, no, I want to keep them on the side. And she's like, she'd never seen that before because she's, well, just wasn't excellent nurse, but just wasn't used to being outside of the hospital that long. So I kept this patient on the side so the blood could keep draining out, and I was able to, gravity held the blood on the low side of the mouth. So I was able to just keep suction going. I told the paramedic, hold the suction in there, hold it in there. And I was able to see the vocal cords, put my stuff in. After I had my tube secured, then I rolled it back. So gravity positioning, in this case, saved me to have to use a lot of special equipment later. Simply gravity, positioning, and that suction. That's what would work with that. Now, many times the way someone comes out of an event depends on the first hands that are laid on them. And I don't think it sounds crazy, but I've seen not to, we don't actually suction enough. If you hear gurgling and bubbling, or someone trying to clear their throat, or having a cough or spit, guess what? They need that out of there. So get it out better now than later. And if someone is, and I've seen where people would aspirate or have a lot of blood in their mouth, and someone go to bagging them and they're pushing it right back down their lungs. And people, the old adage of like, a lot of people will survive the actual event that put them there, but then they end up dying weeks later due to pneumonia, lungs infection, or MODS or something like that. So that's something to think about on the front end. Now, outside of an ET tube, this is my favorite, the King Airway. Service I work for now, we're getting them. I used them on the coast for a long time. We had these as a backup device on the helicopter, and this is a King Airway, and it's a great tool. And in many areas, the advanced EMTs are able to use these. And when we get to do our boot camp, we're gonna have fun with these devices. But you simply just by looking at this, it goes in. Of course, tubes are deflated, and I like this better than the combi tube. The combi tube, you had two bulbs to inflate, and that was you had a little tube, a little syringe, and a big syringe. And once you got that in there, man, I was constantly getting them mixed up. I'm like, wait a minute, that's not the right one. We need to do more on this one. And I hate those devices. So this is one tube that you blow up. And you should check this before you put it in, because things do get damaged. And I have seen those cuffs, those bulbs not work or cut or damaged to where that they're not functioning properly. So blow it up real quick, make sure it works. And when you put that in, you see those lines on the right-hand side of that. There's three lines. Those are where you want to mark it at the teeth. Now, when you push it in, you go to check bilateral breath sounds. Hopefully you got the capnography device there to where you can check the color change. And even if you got an ETCO2 monitor, you can monitor that as well. But when you put that in, you hope to see condensation in a tube going back and forth. And when you hear bilateral breath sounds, that's where you want to secure that at, and note which line you mark it at. Now, some people say I use the lip, or they use the teeth, they use the gum. I don't use the lip because lips swell. And it may not be swollen a lot on the seam. By the time I get to the hospital, that lip is way out there. So how did you have this again? Teeth, if they got teeth, they're not knocked out, that's great. Some people don't have them. But I use, a lot of time I'll note at the gum line, because that's usually not going anywhere. I mean, it can if they're swollen or broke or anything like that. However, it's not, for the most part, it's probably the most fixated object. Let's see. I want to run through this scenario a little bit. We'll take another quick break. But this is a very good rescue airway device. We've had it as a backup. The helicopter, you would try, a lot of times you try with the ET tube right away. And for some reason or another, sometimes there may be difficulty with getting that in, or you can't get it in, and the amount of time that you need to, and you just grab this and then drop it in. Some places this is the first line, like for advanced EMTs, probably the first line of rescue airway in order to get that to get someone's airway secured. You see at the top how it works. The top bulb blocks off the airway to prevent it from escaping at the base of the tongue, and the bottom one blocks off the esophagus, and the air holes are in between those two bulbs, and the only place left for it to go is down into the trachea. Some of these have the distal end is open, and in some of them the distal end is closed. You just have to be familiar with what type it is, and because sometimes they're able to put suction devices and things like that down through them. Let's some alternate. This is, like I said, this is great alternative to bag mouth ventilation when it's required. You're gonna get better compliance with this than you are the BVM by itself, and it is a backup to when there's failed intubation attempts. And what makes a failed intubation attempt? Now, sometimes airways are difficult to get. Someone could be very anterior. They could have a lot of damage or trauma, and when you go to intubate somebody, sometimes their pulse ox or heart rate and stuff might start to drop. And if you're still trying to intubate and that happens, you may want to stop, reconsider, and drop your king and get that in place. Now, the thing about the ET tube is it seals off the trachea where it prevents vomit stuff from going down in. However, with a king airway, it don't really protect against the effects of vomiting and aspiration. So it can't go past that bubble, the bottom bubble, and into the trachea. So it's not going to really control that. And of course, they've got to say this because somebody did it. It shouldn't be used in someone with gag reflex. This complications from this are laryngospasm. Like if you put it in and you irritate the vocal cords, someone is not fully unconscious, that you can start the laryngospasm that close up, be difficult to bag. You can cause vomiting by stimulating the gag reflex. Trauma can result. You can hurt somebody by putting this in if it's not done properly. And it talks about where ventilation can be difficult if the pharyngeal balloon, which is a big one, pushes the epiglottis over the glottic opening. So that's when, if you push it in and you can't bag it, you may want to back that up, readjust, but you want to readjust until you can hear bilateral breath sounds. And these are different sizes. The height and the weight of these are on each one of the devices. So it should be, when it comes open, they look at on the sides of what's the proper size of it, because there should be about 4 sizes. There are at least 3, but now they're coming out with, I'm sorry, there's actually 6 sizes now. So be aware of which size is the proper one for that patient. All right, let's take about 5 minutes right quick. Then we'll get into the LMA. We'll talk about that a little bit, and we'll be winding down. So it's 7:52. I'll be back here about 7:57. I'll take a break. Okay. All right. LMA devices are, I've had them on units before, and air services, and ambulances and stuff like that, but I've never used one. Now, a lot of surgical centers will use this the device as a backup, or actually their primary device, for the simple reason that they don't require sometimes all the way deep sedation. They can be used for someone with a like moderate sedation, but what it does is it goes to the back of the throat and simply directly goes over the glottic opening to let air go in. Now I've had like outpatient surgery and stuff like that before, and I'll say, do y'all intubate? And it says no, we use LMA devices, and they're able to control that. They can intubate if they have to, but for the most part, it doesn't really protect against vomiting or anything like that. But what it does do is provide direct ventilation over that without a whole lot of invasive technique. Now, that's one reason they tell you not to eat or drink or anything like that before surgery to minimize that risk. Because you can see how it just simply goes over the bottom of it. It holds the epiglottis out of the way to where you can get a direct passage into the the tracheal opening. Now, it doesn't require you to have a mask seal. The insertion is blind, but it's very easy. You just follow the contour of the mouth, and there's not a real high risk of damage to the vocal cords or the structures. And it does provide secretion protection from like the upper airways as far as drool or nasal secretions or anything like that that goes down to it. There again, some places do have them as well, but it's probably not your most not your gold standard on the truck as it would be in like some controlled areas. And why would you use this? It doesn't provide the protection as the endotracheal tube does, but there may be times to where that is your company's backup device. That may be because if the patient can't be intubated, a lot of times it's held in place by the hand, or you can put some type of a commercial tube device or even tape or something like that to hold it in place. But it can be quickly removed if need be, because of a lot of vomiting or something like that was to come up. It would probably have to be removed because it simply is not going to protect the airway from that, and it will come out for it. Now, obese patients it's not that effective in because of neck contour, extra tissue in the area. It's not going to allow it to seat as much as it needs to. Of course, the risk of the biggest thing here is the risk of regurgitation and aspiration. It doesn't really control that. That's why it's mainly good for surgical centers and stuff, to where they can control what they have to eat or drink before they come in. It's available in a wide array of sizes, like even for very, very small infants. A lot of times, in the flight service, we actually use the smallest LMA available for very small neonates instead of a king airway for that, because of the delicate structures in the baby's throat and neck, and this would produce that, but it's what we would use for the smallest of the smallest if we couldn't get them intubated. So that cuff at the end, it looks that big oval shape type, that does inflate. So slide you'll slide it in place. When you get it seated, it just seats, don't use a whole lot of pressure. You push it down until it stops, then you inflate, and there again 2 vertical bars on the tube that kind of gives you an idea of how to line this up and secure it. So when we do the boot camps, we'll practice on getting these in and securing them. But there again, you have to be on a constant watch. These you can't just turn away and look around with these. You have to watch this the whole time it's in. That's why one big reason is they keep a hand nearby for the most part, so they can watch if any vomit or blood or anything like that starts to come back up through this tube. The eye gel, it is similar to the LMA. It is I've never used one, but it's a non-inflatable seal. It doesn't really require any type of tubes or anything like that, but it does seat against all the peripharyngeal structures. It is mainly used for just rescue resuscitation. It does have a bite block in place to where to keep people from like if they were to try to bite on it, to sever it in two, but also it's a means of support and securing it. These eye gels, they're color coded, so different sizes demonstrate the different sizes or different colors to keep from getting them mixed up. And it's based on a patient's weight. It's not really height, but it's based on the weight criteria. And the insertion is not very difficult at all. It's a blind setting. You just seat it in just like you do the other one, like the LMA. You just do not have to inflate anything. Now, the Cobra Pla, I've never used one of them as well either. I never had to put one of them in, but it looks like it'll be similar to the other ones. It would seat and it would have like that pharyngeal bulb up against it to hold the to make a seal and keep the air from circumventing around it. It is comes in 8 different sizes, and it's made to where someone has no experience or really very limited training in order to be able to insert this. Like I said, I've never even seen one, I don't believe. And when will we use this? Probably another device used for surgical centers. The patients that are probably at not a big risk of vomiting, because it's not going to do anything to control vomiting or aspiration. And that's why surgical centers are able to control the amount of food or drink before surgery, and they have an anesthesiologist or CRNA that is there to keep a close eye on this at all times to monitor for vomiting or aspiration or anything like that. Now, we can't use this for massive face trauma to the oral cavity because there again, it's not going to prevent aspiration or fluids going into the airway and other places. If it doesn't seat far enough in the mouth, it can cause the tongue, it can dislodge the tongue. It can make it actually stick out of the mouth like some type of an old fish bladder or something like that. But it can cause it to stick out, and by doing that, by displacing the tongue to that point, it will not get an adequate seal. So that's why proper sizing is vital in this type of airway. And there again, I've never used one of those kinds. But it's pretty much the same insertion technique as far as the others. Make sure that the cuff is fully deflated before you insert it. Water type, some type of lubricating gel. And when you open the airway, this is one time you're going to use the tongue jaw lift, to where you actually grab one thumb on the tongue to kind of hold it in place and lift up on the lower jaw, lift the jaw away from the back of the mouth and or the back of the neck, and insert the tube like that, and then let it relax back on top of it. So the tongue jaw lift is what we're going to use to open this. Push it down in place until it seats. Inflate your cuff, and there should be the amount to be inflated on the you see that there's a little bulb, right, or a little flat piece that's at the end of the syringe before it connects to the little flimsy hose. It should have on there exactly how much air is to be pushed into that type of device. This also, any of these devices that I've just showed you, we talked about the colorimetric devices earlier, the Etco2 monitoring devices. Any of those will attach to these to confirm placement. And with any advanced airway, there should be some way on there to confirm placement. At a minimum, the colorimetric. But things you want to look for when those go in is like condensation in the tube, bilateral breath sounds, no gastric sounds. Now, there's possible to hear some gastric sounds with one of these that doesn't seal as good as an ET tube does. So be aware of that. But you don't want to overinflate, because overinflating a bulb can cause tissue damage. Over excessive compression on the surrounding tissue can cause damage in that fact as well. Now, this is the one I said I didn't like. The Combi 2, I have inserted a bunch of them, but I do not like these for the simple reason you've got to use, when you put it in and you blow up, you got to have a syringe for each bulb, different size. And when you go to bag on one, if that other one's not sealed off or compressed, if it's in the wrong place, it's going to blow vomit and aspiration material all over the place. So also, if you start ventilating through one of the inlets and you've got bilateral breath sounds, no gastric sound, it sounds like it's in the right place, that air is going to escape through the other one unless you bend it over and tape it down. You crimp it and tape it down. So to me, I would rather have the King or the LMA instead of this, because to me this has a lot of extra steps that's kind of outdated. We don't need to be doing anymore. That's my personal feelings and past professional experience with these type devices. They are there's a backup in case the patient can't be intubated for some reason, but it does provide a little bit. It does, once you get it in and in place, it does provide better ventilation than just a regular bag valve mask. However, there's a little bit of work to getting this set up in order to function properly. So this could go in a couple ways. Tongue jaw lift could be an easy way to get this in, and it will work regardless of which organ that it goes in, whether it goes into the esophagus or whether it goes into the trachea. So it will work either way. So the jaw thrust method is the easiest way to get this in place, or the chin lift, and if it goes into the trachea, it gives ventilation through the distal end of it. You see the hose around the holes that are in between the two cuffs, and you can see how it will go into the trachea or the esophagus. Now, most of the time it will go into the esophagus for the simple reason that it will have to curve the curvature of getting one up into the trachea. I've put several of them in, and I've never had one to go into the esophagus. I'm sorry, the trachea. It's always went to the esophagus, and we had to ventilate that way. But there again, when you get one working, you'll need to crimp and seal and tape the other hose down to where it won't go out all over the place. So, you can't use these in someone with a gag reflex, someone that needs airway support, or where just regular BVM may not be doing the job. It can be used, it can only be used people that are over 5 foot and over 16 years of age. That is the size parameters for that, because it's not forgiving. It's one size, and that's the range of people that it works on. So putting it in someone that is shorter than 5 foot or under 16, it can be dangerous. It can be deadly for them. So that's the reason for that. Now, someone can be too tall for this, like 7 foot, and why is that? Because their structures are going to be spread out longer than the effective functional area on the tube. So also, since it does go into the esophagus most of the time, we cannot use this in someone that has disease of the GI tract, especially of the esophagus, like esophageal varices, recent gastrointestinal surgery, or recent GI bleeds. We can't really put that in there, because they will simply, it could cause a rupture, it could cause worse bleeding, and then you've got a twofold effect upon you. So there again, this is not one of my favorites, but it is better than not. So when of course, complications of all things can happen, and some things we need to look for is if it's in the esophagus, if it's in the trachea initially, and we're getting good ventilation, and then it slips into the esophagus, you still would be ventilating through the wrong tube if it slips in there, if you're unaware of it. So that's one reason we need to have the ETCO2 devices in place, or the monitoring devices, in order to be able to track if we lose the expulsation of CO2. The confirmation protocol on this, like I said before, to me, it's a lot of steps where there's better tools out there now that we don't have to go through all that. Put it in place. You blow the tubes up. You bag through one tube. Well, that's not working. Let's seal it off. Let's bag on the other one. Okay, that's working. We look for condensation in the tube. We look for bilateral chest rise and fall, absent epigastric sounds. And many times these things will slide back and forth. They will slide back and forth. It's easy for them to move around. And especially like if CPR and stuff like that, intrathoracic pressure and abdominal pressure can a lot of times cause these to become unseated. Now these can't be used in anyone that is has a gag reflex, of course, but sometimes someone may regain consciousness or start to improve, and they can start gagging and having laryngospasm. They can start to aspirate, start to vomit. These can also cause trauma to the structures and the anatomy of the neck because of improper placement. And the large pharyngeal balloon could also actually push the epiglottis down over the glottic open to where it won't seat. It will completely block the air from going in. So to me, there's just a lot of things that could go wrong on this. And if that happens, if you can't get air in either tube or it doesn't sound like it's going in, you may have to readjust, reposition, and if you're not absolutely sure you're properly ventilating the patient, this may have to be removed. So there again, not one of my favorites. So what Airway, do y'all have any? Those are on rescue units, and there's some transport service as well. What do y'all have as backup airways, or do y'all have any of these devices on the ambulances? And do you have any favorites or dislikes that you don't like about any of them? Donnie, do they have these on the rescue trucks in Harrison County yet? Some of these, like the Kings and stuff like that?
We only have intubation kits. We don't have combi tubes yet, or combi intubation.
Okay.
So everyone on the squad, that 9 out of 10 times that's running it, it's going to be a paramedic.
Okay.
So.
Gotcha. Hannah, Donna, anything that y'all use different out there? Any different devices that we may not have talked about tonight? Okay, Donna, got that. You know, a lot of these changes don't come around quickly. So maybe hopefully that's why you're in this class, to bring those changes back to your departments and stuff like that. But if they give you, I don't know if I get in trouble by saying this or not, but if they give you a choice, you know, the king is the way to go to me. So I don't get any commercial kind of benefit or anything from that. However, I'm just saying from personal experience, I'll grab that 10 to 1 before I do somebody else. Yeah, now the king is to me, next to putting an endotracheal tube in, that's the one that I like. So let's see the next step here. The when you put these in, like a lot of the blind ones that go in, like the King, the LMA, the combi tube, talks about the head being in neutral position. You don't want to flex it or hyperextend it. However, that lower jaw a lot of time can make it difficult to get it past the hypopharynx, and that's why we want to. Yeah, Donna, that I'm not going to mention how long ago you said that was, but yeah, you're right. They were, and I hope you may remember in my category, I remember we had EOAs, esophageal orbital airways, and then the EGTAs back in the day. And those things, you would put them in blindly like you kind of do the combi tube, but it was for the esophagus. And honestly, if you let go of that thing, I've seen it come back out of the mouth and fall over. It's just, I guess that pressure, but man, that was some primitive caveman day stuff. So, yeah, I've had them fall on the floor when I turned around to look for something. But so forwardly to place that jaw. The tongue chin lift it up, lift it forwardly, and then kind of, if you'll think about, if you try to picture yourself, it's like I'm going to lift the jaw up and slide this behind it. That's kind of the way that the best way for these to get it to work. Because if you just force it in or push it in without making those maneuvers or manipulations, a lot of time you'll push that tongue and everything back down in there, and that and when the tongue compresses back, it affects the epiglottis position, and that bulk could easily set on all of that and just kind of press it together and compress it together, cause it not to be able to get ventilation in. So lift the tongue and the jaw up, and it functions like you're sliding the device behind it. Of course, once you get it in place, inflate your cuffs and confirmation of ventilation. This should be in red letters here. Confirmation is critical, and that involves every time. You know, you may or may not always see condensation in tube, but that is a good plus. And you want to be sure that you hear bilateral breath sounds, and you want to be able to hear that you hear minimal or no epigastric sounds. And you want to have an ETCO2 device on the end of that, whether it be colorimetric or the digital kind. And how often do we confirm? You confirm that after every patient move, and you document after every patient move. There's a big that they show in a lot of the paramedic schools of this paramedic that was in court. It was a long time ago, and they got to the hospital and the ET tube become dislodged and the patient died of a anoxic brain injury. And they asked him, they said, hey, when you moved the patient from the bed to the floor, did you recheck your tube? He said, yes, I did. Was it documented? No, it wasn't. So those three things need to be documented each time that you move that patient, or either before you hand it off to somebody. And there again, not just to keep you out of trouble, but to make sure that this patient's getting what they need to do the best thing for them. So misplaced tubes that become dislodged, that is a very big problem. So after confirming the breath sounds, securing it, those lines that are on the tubes, make sure you also document and mark at what level they're at. And there again, I like using the gum line because lips swell, teeth may or may not be there or may be missing or may become loose, but the gum line is usually, as far as what you've got to work with, the most stable one. Now, foreign body obstruction that completely blocks the airway, that is a life threat that you don't have a lot of time to deal with. And it will result in death if not dealt with immediately. Many times in adults, it happens during meals. Some things that you want to look for is, like if you're standing there or in a crowded area. See, a lot of time we don't see this when it actually happens. We're there to clean up the mess and the after effect. But just some good information to take with you in everyday life. Someone like in a restaurant that stands up and acts funny, or a big clue. I was an offshore paramedic for a while on some oil rigs, and we were sitting at a meal one day, and one of the guys at the end of the table, he got up and ran out of the kitchen, ran out of the dining room. And I went after him, and I caught him in a bathroom. He was choked, and I had to do the Heimlich maneuver to get it unloose from him. And this guy was I'm 5'8". This guy's about 6'7". I had to coach him to get him down on his knees so where I could get around him to get it. So anyway, strange behavior like that. A lot of times they'll run away or they panic or something. That's like if you see this happening. But like I say, many of the times we're there after it is. So, adults, it usually happens with a meal. Children usually occur while eating, playing with toys, crawling around the house, putting things in their mouth. There has been, you might not when someone finds a person that's unresponsive, they might not know that that's what caused it. That's why we have to do our ABCs, and let's do the assessment and check for these airways. a story that I'll put at this part was simply it was several years ago, but I don't know if you have kids or not, but if you do, a little me time after everybody gets settled down is great therapy. And particular mom had several small kids, and she got them down in bed for the night. And was watching TV, enjoying a little time to herself, much deserved. So when she got up to go to bed, she found her little 2-year-old lying in the floor between the kitchen and the dining room, and unresponsive. She didn't know what to do. Was unconscious. It wasn't breathing. So she called EMS. The fire department got there first, and they were telling me, said, "Hey, air won't go in," and they weren't really, well-meaning people, but they weren't really that trained. So when I go to, I couldn't get air to go in, so I do an abdominal chest thrust. I couldn't get anything to come up, and but air would not ventilate. So when I go in to look at my laryngoscope, this kid he had put a Hershey's Kiss, Candy Kiss, little foil packages in his mouth, didn't unwrap it and chewed it up. And I actually got that candy out from between his vocal cords. But by that time, the kid was already asystole, and and the poor little guy ended up dying. But there again, she had no clue what caused it. And it was because of an airway obstruction. And we have to be able to, when someone's unresponsive, we have to be sure to look for that. I've also been to ones to where one guy lost a contest on seeing how many rolls he could put in his mouth. And I actually, with a McGill forceps, dug about 6 rolls out of the back of this guy's throat. But by the time I got everything out, he'd already become asystolic, and he ended up dying. So anyway, a lot of foreign body obstructions are accidents, and some of them, it's like, man, they happen because of carelessness or problems with that. Someone lying flat, or the biggest airway obstruction in patients that are unconscious or semi-conscious is, of course, the tongue. So early recognition is the most effective thing that you can do. This can also happen because of trauma. It can happen because of a certain type of illnesses to where the airway becomes completely obstructed. And I know it's not a foreign body, but even obstruction of like laryngeal spasms and anaphylactic shocks and things of that nature. With a partial obstruction, you can probably hear air movement. It may come to the sound of stridor or hoarseness, or someone that becomes hoarse over a period of time when you're talking to them. And if a person is able to cough, then allow them to try to get that up themselves, because sometimes that's the best thing that they can do. Now, if there is a foreign body in the back of someone's throat and you can't see it, don't go after it. Don't do it blindly, because it can become wedged further down the throat and make it even more difficult to get it out. So some obstructions can happen pretty quick. Now, we know the universal sign of choking. Not everybody does that. Like I said, some people get up and run. So with poor air exchange, the cough may be ineffective. It may be weak. If it's not working, they need help. If they're able to take in a full breath to get out a big, strong cough, then they probably can start. You can just kind of sit to imagine on their own. But if it's to the point to where the cough is ineffective, difficulty breathing, cyanosis, these people need help. Don't wait to see how bad it gets. So if they're unresponsive, then of course a thorough patient assessment is what's needed. But however, if you're not past the ABCs, that's where you're going to stop at. Will air go in? No. Reposition the head, try it again. If it still won't go in, then you got to assume there's an obstruction and you try to relieve it. If a patient's found unresponsive, don't appear to be breathing, then begin CPR. Chest compressions will dislodge in unresponsive patients now. The new CPR guidelines is, as far as unresponsive patients, they don't do the abdominal thrust anymore. They do chest compressions, which does basically, it may even work better because you're putting that increase thoracic pressure directly over the chest cavity, and hopefully that will expel any type of foreign object that's blocking it. So that is under the new CPR guidelines. We just started teaching them. I've just started teaching them in the last month, so that is a change. Of course, always have suction available in case this does come up. Comes up, and you can suction it out. Like I said, I've got numerous objects out of the back of kids and adults' throats. I've got cigars. I've got Coke or plastic bottle cap lids out. So it's I'd like to think that the worst is behind me, but you never know. And that will end somebody's life quickly. So always assume that people that you work with have a full stomach, because we all know what happens when someone, it seems like they always go into cardiac arrest or code after they eat or something of that nature. Now, and as a disclaimer, here's my sources for the pictures that I put in today. All right. So I was going to back up a little bit right quick just to kind of look at some just to look at some pictures again on some basic anatomy. Now we understand how the CPAP works again with the way the air goes in. This is like a therapeutic type to where it simply, the back pressure, it doesn't force air in. It just, I just want to touch on this a little, just to remind, it just causes a back pressure in order to keep the tongue away from the back of the throat, and it displaces fluid out of the alveoli to where it belongs, to where this gas exchange can take place, and it forms a splinting type. Opens the alveoli like this, the gas exchange can take place. And again, in this one, reminder, the one on the left, you see the fluid in between the capillaries. That space is symbolizing fluid that's between the capillaries and the alveoli, whereas if you do CPAP, you see how it diminishes that space and pushes the fluid out of the way, so the alveoli does have more direct contact to that. Now, like I said, I reiterate on the CPAP because that is one of the things that we're going to use the most as far as advanced EMTs. Going back to the ventilator stuff, I mean, we're not going to have to know these settings and these formulas or anything like that as far as testing, but did anybody find this information beneficial on how a ventilator works or to how to set it up?
Yes, you may use it in the future for education.
Okay. Like I said, that's not something that, as an advanced EMT, would normally have to program in the settings or anything like that. But I believe, and if you know why, the how comes natural. So, but these are just some of the formulas, the way that works, and how this makes the body operate. The biggest thing I want to point out here is that you require a certain minute volume, and maybe y'all can do this when you get off. Remember, figure up your ideal body weight tonight. And that is figured up by your height in inches, but then you do 2.3 times every inch greater than 60. 5'8", you do 2.3 times 8, which is 16. And at the bottom, for males, you add 50. For females, 45.5. And that will give you your ideal body weight. And you simply multiply that by those any of those numbers, but that's the range, and that will give you what your tidal volume is supposed to be. And then ideal body weight. Remember, we do the 120 for the dead space. So ideal body weight times 120. That minute volume, in this case, for a male that is 5 foot 8 inches tall, his body requires about 8 liters of oxygen a minute, or 7,920 cc's of air per minute. That's what he's got to have. Now, if his minute volume, if his tidal volume is at 462, it's going to require 17 breaths per minute. So that's kind of the way that those ventilators is set up and how you select those numbers. And it's actually, if any of you continue on to paramedic, critical care paramedic, or RN or something later on, just if you do, we would use blood gases in order to be able to set these vents up according to that. But anyway, that's, like I said, that's nothing you got to remember for the test for this class or anything like that. But I hope that you got a little bit from it to kind of understand how those ventilators are set up. All right, does anybody else have anything tonight? Comments, questions, or concerns? Okay, the get in here. The next class meeting is slated for, let's see, tonight is, man, I can't believe it's February already. I am ready for warm weather. That's Wednesday the 3rd. All right, Thursday the 11th is what the next class meeting is set up for. The Donna, thank you for the comment. Like I said, sometimes I don't mean to. I want to keep things at the appropriate level so people can understand it. And so, like I said, I hope y'all was able to get something from it. Like I said, again, the next time we meet is on Thursday the 11th. And for tonight, pin number for tonight is going to be, let's see, 23835. 23835. All right. I appreciate the interaction tonight. I apologize for before. I know I get talking long-winded, and like I said, I talk for hours sometimes. I don't realize, hey, people need a break or something like that. So there again, I appreciate the interaction tonight, and I hope y'all have a few days off.
Hey, Lynn, what's the code again?
23835. 23835.
Thank you.
And Hannah, I got your message. That's fine. We know that's why we do it like this. That's one thing about EMS people. We kind of we're crazy enough to all have got into this field, but we work these irregular hours and stuff like that. So we understand why it's difficult with not 9 to 5ers and things like that. So not a problem. But look, if any of y'all have any questions, comments, concerns that come up, write them down. We'll talk about them next time, because I love, I love discussion and feedback, just to make sure that I'm getting my point across. And if there's anything else you need from it, if I don't have it in these PowerPoints, then just give me a little bit and I'll try to get it somewhere. All right. If that's all there is tonight, I'm going to sign off and start my work week. Y'all have a good one, and be safe out there.